So the top educational content part of the annual meeting consists of 4 nuggets of education content that are most impactful to the practicing pediatric surgeon. The Professional Development Committee of APSA collects and curates new information and selects a speaker who can distill this information in a TED-type talk. You heard the first one yesterday from Dr. Sean Kunisaki. The second of these tech talks will be given by Dr. Veronica Sullins. Dr. Sullins is an assistant professor of surgery at the David Geffen School of Medicine. She earned her Bachelor of Science in Biology in Stanford while playing soccer for the US youth and women's national teams. She completed her general surgery residency at the Harbor UCLA Medical Center and her fellowship at a little-known place called Children's Wisconsin in Milwaukee. She, as well as the rest of our fellows, are good representatives of what Milwaukee has to offer. This morning, she will speak about the current NEAL per Oz, or NPO guidelines, and how to implement them in different practicing environments. On behalf of the PDC, welcome Dr. Sullins.
Thank you to the PDC and especially Dr. Marge Arca for not only giving me the opportunity, but also for holding back some of your intel on that intro. I want to start with a clinical scenario. I was on call during my first year in practice and covering both academic and community hospitals, and I get paged from one of the community hospitals around 1 a.m. and the page reads, "Urgent, cannot get IV." I call back to find out that we have a 9-month-old baby with a large abscess who's scheduled for IND the next morning. The nurse tells me, and I can hear these blood-curdling screams in the background, that they've been trying for an hour to get an IV. They need me to come in and place one stat. And of course, my next question is, why do you need an IV now? Because he's NPO past midnight. What I really wanted to say was, wow, the NPO past midnight guidelines were changed over 2 decades ago by the ASA. Why are we still doing it? But I bit my lip, because this wasn't just a nursing issue. So let's take a step back and look at the bigger picture here. What are the age-appropriate guidelines and why? Here are some commonly used guidelines and what are currently recommended by several large professional societies. Clear liquids can be given 1 to 2 hours prior to surgery, breast milk 4 hours, formula and light meals 6 hours, and fatty meals or heavy meals 8 hours. There were several variations of these guidelines. Some separate clear liquids and non-clear liquids, non-human milk, breast milk, and formula, but the evidence is really variable for these specific things. Interestingly, in 2018, several European professional societies issued a joint statement recommending clear liquids up to 1 hour prior to elective anesthesia in healthy children. There's considerable variation even in pediatric hospitals, and every hospital has their own version that's similar to this, some even differentiating by specific age groups. Why do we care? Aspiration risk is what the most commonly cited reason is. The long-standing tradition of fasting prior to surgery was not scientifically based and was instead prompted by early reports of aspiration and the assumption that you cannot aspirate stomach contents if the stomach is empty, which makes sense. In 1946, Curtis Mendelsohn instilled gastric fluid from pregnant patients into the airways of rabbits to induce a chemical pneumonitis, and then named the syndrome after himself. In 1974, Robertson Shirley instilled about 25 milliliters of gastric acid directly into the right mainstem bronchus of rhesus monkeys in an attempt to quantify the volume required to cause the syndrome. But other studies used residual gastric volume to determine risk, but volume in the stomach does not equal volume aspirated into the lungs. Large studies in general anesthesia have not identified an association between aspiration and noncompliance with NPO fasting recommendations in either healthy adults or children. In fact, propofol is an antiemetic, and ketamine with its dissociative qualities actually maintains airway protective reflexes. So what is the actual risk of aspiration in pediatric patients? The number is based on many studies, but corroborated by studies of over 40,000 children, 2 studies in the late 1990s, and 3 more contemporary pediatric studies. The current risk estimate is roughly 1 in 5,000 patients and no measurable mortality. It was previously thought that aspiration risk is decreased with longer NPO times, but extensive studies show that since the 1990s, perioperative risk of aspiration has decreased to 1/3 of the prior incidents despite the change to more liberal NPO guidelines. In 2015, Anderson retrospectively studied over 10,000 pediatric patients over a 5-year period in an institution that had a 6-4-0 fasting regimen. This meant that pediatric patients could have clear liquids up until the time that they were called to the operating room. They found that aspiration events occurred in 0.03% of cases. There were no deaths, no case required cancellation, ICU admission, or mechanical ventilation. In 2020, the German NICS study was a prospective multi-center comparison of 6-4-2 and 6-4-1 fasting regimens. They found that clear liquid fasting times were shorter than recommended in 40% of patients, regardless of what regimen they wanted. There was no difference in incidence and adverse events when fasting times for clears was shortened from 2 hours to 1 hour. And several studies have demonstrated that children who are allowed to drink clear fluids closer to the time of surgery experience less thirst, less hunger, less anxiety, and show better behavior, and are more comfortable and willing to cooperate with IV placement if it's done in the preoperative area. Longer preoperative fasting also increases the risk of dehydration and hypoglycemia and increases postoperative insulin resistance, which may ultimately result in postoperative hyperglycemia. So who is actually at higher risk? A recent multidisciplinary international consensus statement that included an extensive literature review identified risk factors that were repeatedly reported without any conflicting data. Here in the Kelly green bubble on the right, the big one, included airway manipulation, intestinal obstruction, and esophageal disorders. Other risk factors that had conflicting data in the literature in the light green bubble all the way on the right were higher ASA, emergency surgery, and co-administered opioids. And in the yellow bubble, those were only reported in single studies: esophageal endoscopy or surgery, GERD or a hiatal hernia, elevated ICP, and younger age. But this data was very conflicting and had evidence to support either support or refute these disorders. So to debunk a couple of myths here in red, extensive research has shown that there is no association between increased gastric acidity or gastric volume and the probability of aspiration, and both vary widely, especially in children who are NPO. Even in regurgitated clear liquids represent a very low risk of aspiration morbidity, regardless of the volume aspirated. What about gum chewing? Gum chewing increases salivary production up to 10 times in the first minute of chewing. Evidence shows that gum chewing actually promotes GI motility and emptying in the appropriate age patient. It can reduce anxiety and discomfort, and kids kind of like gum. So chew gum up until surgery, but don't swallow it. I don't know if that's considered a light meal or a heavy meal, but your anesthesiologist will not be happy. So the goal of this talk is not to change your clears from 2 hours to 1 hour, or to separate formula and breast milk if it isn't already, or to try to interpret your anesthesiologist's NPO mood ring. Thanks for that reference, Sarah. But more to discuss the problem that I referred to earlier about the community hospital. The reality is that most of the care of children in this country is in non-pediatric centers, and those centers are often using NPO guidelines that have been proven to exceed recommended NPO times. And they cause irritability, dehydration, hypoglycemia, and are often variable even within the same institution, because different anesthesiologists have different training. They're often fixed practices, and many cite medical legal reasons for being unwilling to change. Even at my own institution, as a QI project, pediatric anesthesia a number of years back retrospectively reviewed the EMR for liquid NPO times in our pediatric patients. The average liquid NPO time was 576 minutes. That's 9.6 hours. And the inpatients were only worse, understandably so, because they were usually waiting for surgery and didn't have a scheduled OR time. They averaged 10.6 hours. Again, the goal of this talk, not to make minute changes to your own practices. Many of us cover community hospitals. Our group covers 9 in total, some academic and some are community. But we really need to be ambassadors for change so we can deliver safe and effective surgical care to kids everywhere. So how do we implement change? The first step is opening the conversation. In the scenario I first presented, this involved a direct discussion with the anesthesiologist covering the case. Meet on common ground. What anesthesiologist wants a hypotensive baby after induction? All you need is one anesthesiologist, maybe 2, maybe for a quorum, somebody higher up that can maybe lead. Next, present the data at department meetings. Anesthesia, perioperative services, Department of Surgery, nursing, pediatrics, even family medicine if they're involved, any of the stakeholders who are at your hospital. Have the information easily available in a pocket card or a PDF, complete with references, and make sure it's a meeting where they serve food. And finally, educate and disseminate, especially with the nurses, because they will be your biggest advocates once they understand what it means for patient safety and comfort, and also for their job. It just makes it easier. Arrange for the hospital to do in-services with the pediatric floor nurses, the NICU, the PICU, the OR staff, even the ED. Have an NPO sign that gets printed and placed on the patient's door or on the patient's chart with the exact times for various food and drink. And maybe even work with the hospital informaticists to have an order set so it's protocolized. So back to the 1 a.m. page. Rather than making some snide middle of the night comment, I told the nurse to give Pedialyte and I would call the anesthesiologist early in the morning. Again, the take-home point is not that we need to change clears at our institutions from 2 hours to 1 hour. It's that we have a responsibility to bring safe care to all hospitals where kids have surgery. And the beauty of establishing a pathway for NPO guideline implementation is that it can be repeated for other pathways in common pediatric surgical conditions, such as appendicitis, pyloric stenosis, G-tubes, and in some of the higher levels of pediatric community hospitals, gastroschisis and trauma. We would never have thought that community hospitals would embrace non-operative management of acute appendicitis, but it's happening in LA. So take-home points. Number 1, don't get mad at the nurse for that middle of the night page. That's for you, Steve Lee. Number 2, know the appropriate NPO guidelines. And most importantly, be an ambassador for change so that we can deliver safe surgical care to children wherever they're being cared for. Thanks to the PDC and to both Marge Arca and Steve Lee for their conspiring against me and also for their everlasting mentorship.
Dave Notrica, Phoenix. Your comment about getting the IT service on board is really insightful. We started to make progress when we deleted the NPO after midnight order, because just giving the option wasn't good enough. We had to get rid of it.
That's a great comment, thank you. Yeah. He said he deleted the NPO order from the order set.
Ronnie, hi.
Hi.
Kirk Reichert from Wilmington, Delaware. Great talk.
Thanks.
We've been fighting this fight for a long time, but now our most common reason for day of surgery cancellation is we still haven't figured out how to communicate this to the families, and I wondered if you came across any kind of best practice guidelines for that.
Yeah, you know, it's interesting. There wasn't a best practice guideline, but that's also where anesthesia comes in. Because oftentimes it's a perioperative anesthesia nurse or resident, depending on where you are, who's calling the family beforehand. And interestingly, in some studies, the perioperative NPO times were not followed because they were actually shorter than the recommendation, the European studies in particular. Whereas at our hospital, you saw the NPO guidelines for outpatients were not followed because the parents just didn't know and they wanted to be safe and not have their surgery canceled. So that's, I think, an institution-specific problem, and you'd have to figure out like who is the ambassador for the OR services, who is communicating that to the family. I tell them that when they first come in to my office, but sometimes they receive other information.
Mehul Raval, Chicago.
Hi.
Hey. So this is really fantastic, and I know that as we go about trying to implement various enhanced recovery protocols, this is a key aspect to mitigating some of the perioperative stress that our patients are undergoing and being successful with implementation of those protocols. So one of the things that we've struggled with in our efforts to do that is is understanding the timing as it relates not to the first case starts, for which this could be very well planned, but any advice that you could offer those of us that are trying to do this in the real world in terms of subsequent cases when we have a cancellation for another reason, and then we're unable to then get those patients to the operating room because they have been drinking a Gatorade on the way to the hospital or whatnot.
That's a great point, and usually the reason for inpatients having a longer NPO time because they don't have an actual start time that's accurate. I think this was actually the impetus for some of those European hospitals to be nil per os up until the time they're called to surgery. And I think that it's, we probably aren't ready to do that yet, but if you have it at 2 hours before, then at least direct communication with the operating room if there's something that's going to be taking longer. That needs to be very clear, and you have a contact person who's like the nurse who's saying, hey, call into the operating room and give them the number just to find out what exactly the times are so they can be more accurate, but that's a big problem. Yeah. Dr. Calkins?
Casey Calkins, Milwaukee. Ronnie, that was predictably fantastic. I have another scenario for you. So the complex trauma or burn patient who has a post-pyloric enteral feeding tube for nutritional support. My question for you is, when should we stop the feeds, or should we stop them at all?
Don't stop them.
At all?
Don't stop them at all.
Love it.
I'm Ron, Corpus Christi. The other issue with keeping patients NPO is the data out there that says that it actually helps with more rapid pain extinction after surgery. Is there any information out there at the balance of when that takes effect and when it's the appropriate time to get both the benefit of being NPO for pain extinction and also reducing risks?
Sorry, for pain distinction?
Pain extinction.
Oh,
how
pain
quickly
extinction.
pain goes away after surgery.
I didn't find large studies about the association between NPO status and pain particularly, but I did find some data related to pain medication, enteral pain medication administration, and depending on the type of surgery, and this is going to be one of the nuances that has to be specific to those patients, just like the ones with high risk. That you're just going to have to discuss with anesthesia, but it is safe in most surgery to be able to administer enteral pain medications.
Thank you so much, Dr. Sullins, for a wonderful talk.